Hello, welcome to our 14th COVID-19 webinar from New York Medical College and the Touro College and University System. I'm your host. My name is Edward Halperin. I am the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of the Touro College and University System. For those of you who have been joining us for these webinars since 2020, you are probably thinking he has run out of ways of saying, well, here we are again. And at the end of these webinars saying, well, I hope we would be over with these webinars because the pandemic is over, but I guess we'll see you again in a month. And that is all true. So I think the only way to begin these webinars is, hello, welcome back. And when we conclude today, it will be, thanks for joining us. We'll see you next time, because there appears to be no sign of this abating. Our program for today has been selected through a combination of your comments and feedback from our previous webinars, and some topics that I think would be of interest that we haven't touched on for a while. And as I always say, we've got some old friends back to speak with you again, and some new friends for you to meet. We're going to tackle 4 topics in our general presentations today. First, you're going to hear from the Dean of the School of Osteopathic Medicine of Touro University, Nevada, Dr. Wolfgang Gilliar, who's going to teach us a little bit about what it's like to try to run a medical school in the middle of a pandemic. And it will probably give many of you insights to the difficulties of higher education in general during the pandemic. And then it's time for one of our old friends, Dr. Marissa Montecalvo, will be back to talk with us. Dr. Montecalvo, as you have come to know, is board certified in internal medicine and in infectious disease. She's going to tell us all about the vaccine, acquired immunity, issues of booster shots and third shots, topics which we know from your previous comments are of great interest to you. Then it's time for a new friend, someone you haven't met before, Dr. Susan Shapiro. She is a professor in the Touro Graduate School of Education. Her particular specialty is early childhood education and special education. And I've asked her to teach us about the impact of the pandemic on school children, on their progress in education of all this online learning back to the classroom, in the classroom with a mask, maybe not in the classroom. It's a topic that's concerning many people. And then our 4th speaker is going to be one of our old friends who we've met before, Dr. Karen Murray, a professor in the Department of Obstetrics and Gynecology. We had so many questions at our last webinar about, I'm thinking of getting pregnant, or I am pregnant, should I take the vaccine, as well as questions about breastfeeding and the vaccine, that I've asked Dr. Murray to come back and talk with us about the latest data on both of those topics. I'll be back to visit with you again in between the speeches to tell you how to get your continuing medical education credit if you'd like to get CME credit. And remember, for this webinar, as for all of our webinars, if you go to the place on your screen for Q&A, type in your questions. We'll be monitoring them in real time during the webinar, and we will get to as many of the questions as we can when we are joined by the president of the Touro College and University System, Dr. Alan Kadish, who will be our Q&A moderator, as he has been for all of these webinars. Thanks for joining us. We hope you find this an interesting and valuable program. And let's get started with Dean Gilliar of the Touro College of Osteopathic Medicine in Henderson, Nevada.
Hello, I'm Wolfgang Gilliar. I'm the Dean of Touro University, Nevada College of Osteopathic Medicine, and I'm delighted to speak with you about the trials and tribulations that we have experienced the past 18 months, but more of what we have learned and what the pandemic taught us in those 18 months so that we can go forward with a better and new ways of delivering our charge medical education. As a disclaimer, I have no conflict of interest to disclose, and so let's go right into the meat of the matter. So what did the pandemic teach us how to deliver medical education? That's a central question, and I thought I would bring it in 5 topics altogether. First, I would like to present medical education, some of the basics for everyone as to how we actually build medical education and where it fits in to the landscape of education in general. Then what the crisis and the chaos did with the pandemic. And then from that, we want to look at some of the emerging new ways, some of the directions that we will gain or have gained through going through these past 18 months. And then I would like to end with really where the rubber hits the road, in my opinion, and probably many of our colleagues, is that whatever we do in education, and yes, sometimes it's very stressful, and sometimes it is very unknowable, it is this blank space, it is in the end a personal mission, and I put in the word personnel because all of us are involved. And hopefully at the end, we can look at some of the message and the messaging that we would like to continue going forward. If you look at the landscape of medicine, of the medical education, there's about 4,000 colleges, universities. These are typical 4-year universities or colleges in the United States. These are all rough figures. Of those, if you look at, there's only 155 accredited MD schools in the United States, and the MD schools are accredited by the LCME, which is the liaison of college accreditation for medical education. And we have 38 accredited DO schools, which are accredited specifically by the COCA. Now, if you look at the numbers, we in the United States have about 90,000 MD students at one time and 33,000 DO students. That means that out of every graduating physician going forward, 1/4, every 4th graduate will be actually a DO. This has been an incredible explosion, and we all together, both MD and DO schools, had an increase of 50% of a production of physicians in the United States since 2002. If we look directly at Touro University, we have about 2,000 MD students at any one time with the New York Medical College, and we have altogether about 2,300 DO students at any one time in all 4 years in the 5 medical colleges that are housed within the umbrella of Touro. We have 4 DO colleges. We have the 1 MD college, which is New York Medical College, and we are growing as we are planning to add 1 more college going forward. So I would say that within the next 4 or 5 years, we may actually have close to 5,000 medical students altogether. So if you look at the way we teach, it is actually the United system, the healthcare system in the United States has been what I call antiquated. It has been almost fixed in antiquity. And what I mean by that is we, even in 2020, had what I call the old model of the late 19th century and clearly carried that forward from the 20th century. And what that was is that we have a medical education system that is built on a 2+2 system, where we have 2 years of pre-medical education, which is the basic sciences in general, and then 2 years of clinical education, which is the clerkships or the various preceptorships, etc. That's the system within which we have lived. However, we have learned to now get education done within the health systems from clinical practice, and research informs what we teach, and they also practice what we teach. So therefore, it is this wonderful loop together. However, as a pointer, the the education has happened, and this has become really, really important over the last 18 months. It is no longer in an isolation. It's no longer in a vacuum. And therefore, we are moving forward in the societal way with economics constraints and the political background. There will be about 130,000 resident physicians that are the ones where medical education occurs. Now, when we look at the crisis and the chaos in the pandemic, really all delivery stopped overnight. We had one fear: can we educate our students in not only 2020 but also 2021? And we found that each class has its own issues, and with that, we realized we have to look at each individual class itself. We had to look not only at the delivery and the content of knowledge, but also the skills and how can we continue this. And we had to wonder, will the accreditors or the other associations like the Council for Graduate Medical Education, AAMC, ACOM, all of our parent organizations, how will they respond? Will they support us, or will they be extremely strict? How will be everyone moving forward? What board examinations will happen? What, where, and when? What will rotations look like? And what will this match in 2020, 21, 22 look like? I'm very pleased to let you know at Touro and in the entire system, we have done phenomenally well, both in the match 2020 and 2021, and fingers are crossed for 2022. Now, when we look at the emerging new ways, what are some of the points that we have actually learned? Clearly, we have learned that the sage on the stage no longer is there, and that person has given way to the coach or the guide on the side. We have gone into more virtual learning and video conferencing. The new word is video conferencing, virtual learning, and clearly goes into hybrid. And hybrid is any format of combination of different styles of delivery of education. And that can be via videotape or in small group learning, etc. We have had innovative solutions, including now integration of ultrasounds. For instance, we are giving ultrasound probes that are non-tethered, they're wireless, to our second, third, and fourth year students. We have telemedicine that before was what I call in a slumber, and all of a sudden woke up like the new person awake, and that was really a new way forward. Social media has become an incredibly new way of integrating medical knowledge and how it is being disseminated among medical students. And then we know that small group learning still, even if it's online, virtually, has a significant amount of learning activity and value. And therefore, looking forward, alternative skills testing has also become a new way, and planning, really planning is the key here. Now, when we talk now about us, the person who really are doing this, or our students, and I will tell you the face of medicine looks, I think, very positive, because our students are just ever so dedicated and driven and emotionally involved, and they bring this. I call this, they bring that skill set already, which is an extreme plus for us as educators to work with our students. And I cannot tell you how much I appreciate that. We have been teaching something called along the biopsychosocial sphere. And now what we have been doing since the pandemic, I think we have increased the psychosocial and at the spiritual spheres, so that our students really feel they contribute not only to their own learning, but also to the greater good. We are now looking at synchronous versus asynchronous learning, that a student can actually learn anytime, anywhere. And it is individual learning versus group learning. Now, I can say, and we can say, that old assumptions of what I call the salami science, where we go piece, 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 that need to be replaced by a spiral up, so that the learning happens much larger as we go forward, is that our students really are learning to handle their time. And with that, the need to plan and being organized becomes ever more important. And I would like to say that all of us, those who educate, faculty, staff, and everyone supporting our students, has really come together in a way to facilitate a learning moment. And I can only say that I am extremely proud of everyone, no matter what was thrown. We had our own issues in Nevada with diseases or disorders, to the point where everybody says, no, can it get any worse? And thankfully, we are coming through. So the faculty has led by example, and that really is the key for our success. Now, if you look of what the pandemic can teach us, clearly the message and messaging and communication becomes very, very important. It shows that whatever we do needs to have clarity, consistency. It needs to be specific for the cohort. Is it the class of 21, 22, 23, 24, 25? I would say that the class of 2023 is the one that has gone through what I call the roller coaster in the most heavy way. They first learned in the old way in the first year. They had to go to the immediate online in 2020, and now they are going to a new world in the clinical world. I really think if we had to take one class as the example how they can adapt to and adopt new ways, it's the class of 2023. The new word is flexibility, dynamism, fluidity, and we have to be able to be fluid. We have to be elegantly fluid. We have to have new expectations of ourselves, of others. And what's really clearly shown is mental health are requiring safeguards. We have to be there for safety, volunteerism, and we have to look again at the mental health and the support and the well-being of our students. So I would like to read to you a summary that a student sent to me just this summer. And she said, I just wanted to say thank you for exposing the first years to clinical skills and allow us to have anatomy lab, both dissection and prosection in the midst of the pandemic this year. Needless to say, almost all the second year medical students in the program, she was at Mount Sinai at that time in New York this past summer, they have had no in-person clinical skills training and did not have dissection portion of the anatomy lab. Kudos to Touro. I'm so thankful for the experience and have been able to perform physical examinations on patients during rounds because of the exposure I had this past year. I don't think we could have had a better endorsement. Now, if we go forward, is the lessons learned. This is a collection from summary points from students, faculty, and staff. We can go paperless. We need to, we can make medical school accessible to wider communities and interest groups. We need to be more flexible. The students learn more to take personal initiatives, and with that initiative comes more planning. And they say, I woke up to read more. Wow, what a surprise. And we were prepared for, or they were prepared for more laboratories because they were learning asynchronously how best to prepare for themselves. And the thing is we built new norms. This means we've gotten off our old horse of old routines. What are some of the take-home points? We must remain open to new ideas, our own and those of others. We must be critical, but we must also engage in dialogue, and we must listen. This is a major learning point again. Education really needs creativity, and we should be allowed and invite experimentation. Accreditation may look at new ways of supporting learning rather than just seeing if things are being done in a very methodical one way, what I call follow the book way. And we have an extreme pride in our students and residents. They are our future. I think together we can solve this. And as it says that it takes a village to raise a child, I can say it takes many communities to educate a physician. And it takes society together to support and sustain a healthy medical and health workers workforce. And with this, I want to thank you for your attention, and I hope I was able to give you some of the visions forward as to what medical education can do and where we can go next. Thank you.
Hello again. This is your host, Dr. Edward Halperin, with information for those of you who wish to get continuing medical education credit for participating in today's webinar. You have 3 ways to get your CME credit. You can send a text message to 828-295-1144 and type in the code 94PROP, P-R-O-P, all capital letters, 94PROP. And if you do that, you'll get a response text message back with instructions as to how to fill out your satisfaction questionnaire with today's webinar and how to get your CME credit. If you don't want to use the text message route, then go to the website www.eeds.com, click on the sign-in button, enter that same code, 94PROP, and you will once again get instructions to how to get your credit. Or you can use that app on your cell phone and scan the QR code, and it'll make a dinging sound, and it will take you to the website to get your CME credit and fill out the satisfaction questionnaire. Any of the three ways will work, but any of the three ways will only work until Monday, August 30th at 12:30, when the system will shut down. So I recommend that if you want CME credit, you go on ahead and do the bit of work to get it now, so you won't lose the opportunity when the system closes down. Meanwhile, as you continue to participate in today's webinar, if you have any questions for our panelists, please type it in on the Q&A function on your screen, and we will monitor the questions and answer as many of them as we can when Dr. Kadish moderates the Q&A portion of our program. And let's return back to our program.
Good afternoon. I'm Marissa Montecalvo. I'm an infectious diseases physician here at New York Medical College and the Director of Health Services. And I'm speaking on vaccine protection for SARS-CoV-2. What can we expect? I have no conflicts of interest to disclose. So I thought I would begin with a slide that perhaps you've seen before, the vaccine life cycle, which begins with studying a vaccine for safety, then the phase 1, phase 2, and phase 3 studies. Phase 1 and phase 2 usually being to look at immunologic response in the laboratory from vaccine administration, and then phase 3 looking at the prevention of disease. After that, the vaccine goes for FDA review, then American College of Immunization Practices review, and finally safety monitoring, ongoing safety monitoring after authorization or approval. And of course, we are here. I want to mention that from all the vaccine safety monitoring that's done across vaccines, it's fairly clear that adverse events from vaccines usually occur within 6 weeks of vaccine administration. I'm showing you here the study design for Pfizer for the study that led to the emergency use authorization. And I'm showing this to you because I think it's important that we understand the design so we know what to expect from these vaccines. Pfizer, Moderna, and the vector vaccine by Janssen all had an almost identical design. So after full administration of the vaccine, there was active surveillance, which is where the blue arrow is pointing, to look for symptoms of COVID. If one were symptomatic, they were then tested. The entire cohort gets followed for 2 years, but active symptom monitoring is for 6 months. At the point of emergency use authorization, the data that were available were for active symptom monitoring and testing out to 2 months post-vaccine administration. These are the 3 vaccines that are approved that are authorized in the United States, and you're familiar with this. The 2 messenger RNA vaccines by Moderna and by Pfizer, and the adenovirus vector vaccine by Janssen. So the first studies were the non-clinical studies that looked at neutralizing antibody after vaccine administration, and the response was greater. The response of neutralizing antibody was greater after vaccine than it was after natural disease. And these vaccines also elicited strong T-cell responses. The primary endpoint was this. It was efficacy against symptomatic disease. These numbers, 94%, 95%, numbers that everyone is aware of, were outstanding. The vector vaccine was 72%, but remember that this study was done at a different time interval, different variants in circulation, and across several continents, different from the messenger RNA vaccines. The other endpoints were protection from hospitalization and severe disease, and the vaccines performed even better against these endpoints. However, the limitations of these studies were first that for the messenger RNA vaccines, these were predominantly US data. The persons who were excluded, pregnancy was an exclusion, and any immunocompromising condition other than stable HIV infection was an exclusion. And because the endpoints were symptomatic disease, hospitalization, and severe disease, there are no data from these studies regarding prevention of asymptomatic infection. I wanted to go over a timeline of what's gone on over the last 8.5 months, because I think not only is it remarkable, but it helps to focus us as we think about what to expect. So December 11th was the first authorization for the first vaccine, the messenger RNA vaccine produced by Pfizer for ages 16 and over. 1 week later, Moderna received its messenger RNA vaccine authorization. February 27th, the first vector vaccine was authorized for approval. That vaccine was placed on a temporary pause for 11 days because of cases of cerebral venous thrombosis. The FDA and the American College of Immunization Practices reviewed all the safety data at that point. And at that point, approximately 8 million doses had been administered. And it was determined that although this is a very serious complication, the numbers were so few, given the number of vaccines that had been administered, that it was not a reason to continue with any pause for this vaccine. In April, as more vaccines were administered, we also saw rare cases of myocarditis after administration of the messenger RNA vaccines, and that is now part of the required reporting to the vaccine safety database. In May, the emergency use authorization for the Pfizer vaccine was amended to include children ages 12 to 15. Just 2 weeks ago, both messenger RNA authorizations were amended for a third dose for immune suppressed persons. And that is considered a third dose as part of the primary series of vaccine, not a booster, because in these situations, it is thought that the immunosuppressed persons have not responded to the initial vaccine. And of course, just this past Monday, the first FDA approval. And that approval was for ages 16 and over. For ages 12 to 15, the Pfizer vaccine is still under emergency use authorization. So over this remarkable time period, there obviously have been many other studies besides the original ones. In Israel, over 500,000 people received the Pfizer vaccine with an efficacy of 94%. There were data that were published on adolescents, more and more data coming out on pregnancy, immune suppressed populations, and the duration of protection across all groups. This is another way to look at vaccine efficacy. You can go to the CDC website data tracker and produce this at any given day. What you're looking at here is by age category, and I've chosen fully vaccinated. The proportion in blue, the percentage of the population that is fully vaccinated, and in gray is the case rate of SARS-CoV-2 cases over time per 100,000 population. So as we look across, we can see certainly in the 50 and over group, the higher percentage of the population that is vaccinated. And along with that, you can see how the case rate and the August increase that everyone is experiencing, how that August increase is blunted in the older age groups where there are higher rates of vaccine, of percentage of people that are vaccinated. So I think these are useful data that clearly show that as you have more as you have a population that is more fully vaccinated, how your case rate is lower. Going to turn now to the immunosuppressed population and what led to the amendment. So on August 12th, the American College of Immunization Practices met and reviewed data from 63 studies, which are summarized here. These are studies in which the percent of patients in each study that had an antibody response are charted, and that's along the y-axis. And so you can see that for hematologic cancers, which are depicted in dark blue, you have several studies where less than 50% of the population had an immune response. It was even worse for organ transplant and for some immune suppressive therapies. So this led to the recommendation, based upon these laboratory data of antibody response in these populations, for the recommendation for a third dose of vaccine. In real time, in France, a third dose has already been administered, and that was just published in the New England Journal, that of 59 solid organ transplant recipients who were seronegative after 2 doses, that after a third dose, 44% responded to that third dose of vaccine. So here's what the amendment says, which is that a third dose is indicated for the following groups: active or recent treatment for solid tumor or hematologic malignancy, solid organ or stem cell transplant, severe primary immune deficiency, advanced or untreated HIV, and the immunosuppressive agents listed. It is recommended that a third dose be administered at least 28 days after the second dose, and all that is needed is for the patient to attest that they have these conditions for a site to administer a third dose. So what about the non-immunosuppressed? Well, I think I tried to organize this across the 2 sets of data, which are looking at antibody persistence in the laboratory, neutralizing antibody and other markers of immunity, versus actual clinical protection from disease. If we look at natural infection, there's antibody detected and persisting at least 8 months out. But a year ago, it became clear that persons were getting reinfected 3 months after natural infection. So despite the presence of antibody, there were still clinical data of reinfection. For the vaccines, the messenger RNA vaccines, there are data for antibody protection out at least to 6 months with similar clinical protection. And the vector vaccines, for which there are fewer data in the United States, but the data that exist are out to 8 months, and clinical protection in a small study out to 8 months. So should someone be vaccinated after natural infection? Well, this is an area that the CDC says yes, and I want to just point out a couple of things that have gotten quite a bit of press. So there were preprint data from the Cleveland Clinic that said that if you had natural infection, given that antibody was still present, they looked to see whether the healthcare workers really needed to be vaccinated. And over a follow-up period of 5 months, the rates of infection amongst the healthcare workers who had natural infection versus an unvaccinated versus those who were vaccinated were similar. However, it was only a five-month follow-up. And so I don't think that says that you shouldn't be vaccinated at all. And in fact, there are immunologic data that are very impressive, which are that when you vaccinate someone who has had natural infection, they actually get an immune boost from the vaccine. And not just an immune boost, but when when testing is done in the laboratory, there is better protection against variants. And so it's a boost with a broader coverage. The current CDC recommendations are to vaccinate really anytime after you're off isolation from natural infection. But waiting for 90 days is reasonable because reinfection within 90 days is very rare. Going to turn now to the issue of variants because everyone is concerned about how efficacy is affected by variants. So you're familiar with this slide. These are the CDC variants of concern, termed variants of concern because they have clinical ramifications. So they are classified according to their World Health Organization label, alpha, beta, gamma, delta, the Pango language, and then the country where they were first detected. So although the alpha variant is more transmissible, does not seem to have an effect on vaccine immunity. The beta variant is by far and away the variant that has the greatest effect on vaccine immunity in the laboratory, showing a 7.5-fold reduction in the neutralization antibody response to this variant. The gamma variant also has an effect on immunity, and the delta variant, which is the predominant strain that is currently present in the United States, does have the mutation to have an effect. In the laboratory, it was almost a 3-fold, a 2.8-fold effect. So what about clinically in real time? So for these 3 variants for which there are studies, I put together here what are the published studies and what are the preprint studies, and what the data look like for these variants in terms of vaccine protection for symptomatic disease. These studies also have information about the prevention of hospitalization, and as a general rule, the efficacy is always higher for the prevention of hospitalization. So beginning with the alpha variant, the messenger RNA vaccines continue to perform very well, as does the vector vaccine. AstraZeneca is not available in the United States, but that is the vaccine for which there are published data. A vaccine which is not yet authorized or approved in the United States, the recombinant nanoparticle vaccine. That phase 3 trial was performed in the United Kingdom, where the alpha variant was very prevalent and showed excellent efficacy. As we know from the original trial with the Janssen vaccine, the beta variant is a problem when in terms of vaccine efficacy. In that original trial, the rates were lower in South Africa. The vector vaccine from AstraZeneca performed very poorly against this variant, and there are discrepant data in terms of the messenger RNA vaccines. The Delta variant is what's of most concern to us now, and in data that are published from the United Kingdom, the vaccine continues, the messenger RNA vaccine and the AstraZeneca vaccine both performed well, although clearly with a slightly diminished response compared with the alpha or with the other strains that were present a year ago. So given that, we can expect some breakthrough infections. And I just want to point out this study that was published in the New England Journal from Israel, where they reported on breakthrough infections during the period of the alpha variant being the predominant strain, and they tested healthcare workers for symptoms or tested them post-exposure. And they had 39 breakthrough cases, What's important here is that these cases were had mild symptoms when symptomatic, and a third were asymptomatic. But despite the mild clinical ramifications, they still appeared to have a high viral load based upon the low PCR threshold that was detected on the test. So the clinically breakthrough may not be that bad, but it still can be highly transmissible. So boosters, everyone wants to know about boosters. And this is what was presented at the American College of Immunization Practices meeting. The manufacturers are working on it. They're also working on second generation vaccines. And the FDA is in the process of reviewing these data. As of right now, we do not know when they will say a booster is indicated, but it looks as though things are moving in that direction. So, vaccine protection, what can we expect? Well, I hope that through this talk, I've been able to summarize for you the data, which I think are very clear that even with the Delta variant on board, these vaccines are providing excellent protection against severe disease and hospitalization and symptomatic infection. But the variants do have an effect on vaccine, luckily very slightly for the Delta variant, and we can expect some breakthrough infections. More data are clearly needed to understand the role of vaccination in the prevention of asymptomatic infection. I think the key message is that we're going to really have to be patient. No one was expecting August to be like this and to have the rise in cases while we were still in the summer. And I just want to point out to you a nice article in Monday's New York Times that the science of the virus keeps evolving and frustrating. It speaks to how difficult it is for the public to really be watching science evolving real time and to see the contradictory, sometimes what appears contradictory information, and the importance for people to understand the patience that's needed as science evolves. And again, the FDA and ACIP will be reviewing the data for boosters. So in the interim, I think it's pretty clear that we're going to have to need multiple preventative measures simultaneously. In infectious diseases, we believe in redundancy. We never think there's a simple solution to anything. So I think, you know, we're going to need face masks. Some distancing may be needed. And I think although we are all so focused on that booster, and when should we be getting that booster, it's very important that we also continue the primary vaccination efforts and seek to understand the complicated reasons why people may have vaccine hesitancy, and to really, try to work with people on that and to try to get those people to accept vaccination. And finally, to remember that there can be breakthrough infections. And so even if you're vaccinated, to please stay home if you're not feeling well, get tested, and be sure of what's going on. I want to thank you very much for your attention. I look forward to your questions. These are my references. There's just an endless amount of information about this topic, but I tried to organize these chronologically for you. And these are the major studies that I used. Thank you.
Hello, my name is Dr. Susan Shapiro, and I'm going to be presenting The Children Have Been Going to School Virtually for a Year. Now it's back to the classroom. What do we know about the effects of these transitions on the educational process? And I'm an assistant professor of early childhood and special education at the Graduate School of Education. So when we think about COVID-19, we may think about the virus, we may think about its effects on society. I mean, here in New York, we've really dealt with a huge amount of strife and death. You know, if you look at how it affected globally, you can see that it's had a huge effect on the economics of the world. So COVID-19 has certainly been something that has really impacted us all. Now, one thing that it certainly impacted was schools. And on March 16th, 2020, New York City schools went remote. We were no longer learning in person. And this was something that also happened globally. You can see around the world, schools shut down and children had to then take on education in a variety of different ways. So how did education respond? Depending on where you were in the world, you started to receive education in a different way. So here in the United States, a lot of schools went to online platforms. They used Zooms. They were really dependent on the internet. In some countries, children sat in front of the television at certain times of the day, and teachers would come on and they would give their lessons. In other parts, they were listening to the radio, and still more had take-home packages where they received Xerox copies of the work that needed to be done and did not receive any direct instruction. So although we spent a lot of time thinking about remote instruction, one of the things that we noticed was, at least here in the United States, and this was also something that happened globally, lots of children just simply did not attend. So only 9% of children in America were 100%, were attending 100%. A lot of the children were disappearing and were certainly not going on a regular basis. And the more that children were in poverty, the more that we saw this effect magnetized. This also happened with participation. Although the children might be there, you know, it was a huge number of children really felt that they were not engaged. So they were there, but they weren't necessarily participating or really felt that they had anything to do with the schoolwork. One of the reasons for this not only had to do with maybe children didn't feel engaged with the material, but children were dealing with some very serious issues. Children were dealing with poverty. They were dealing with food insecurities. They were dealing with homing issues. And we can see that this really affected children all over the world. Globally, 71% of parents said that children were having mental health issues, that they were really suffering in dealing with this pandemic. And once again, one of these issues was the fact that children were hungry. Children were dealing with poverty. Children were dealing with parents dying. So really there were huge issues that were going on for children, not only in America, but all over the world. So what happened with this? Well, we wanted to make sure that children were going to catch up. This was one of our big issues that we had. Are children going to fall behind? And of course, children were going to fall behind because they were dealing with these larger issues. They were dealing with programs that were very difficult for them to feel engaged with, if there were programs at all. So there were remedial programs that were offered to children. And depending on how much money the countries had, the more programs that were offered. But children in low income areas and low income countries didn't have these same resources for remedial help that children desperately needed. Here in New York City, we've instituted a Summer Rising program to really help support children as they come back in schools. And one of the things that we know is that when children come back to school, not only are they going to be dealing with an academic loss, but they're also going to be dealing with huge social and crisis needs. And hopefully by having these programs, they will give them the support they need. But we really don't have any statistics on this yet, but we know that this will be an ongoing issue. So what do we know about the effects of these transitions on the educational process? Well, we know that poverty is going to play a large role in the need for remedial support. The more that children have dealt with poverty, the more they're going to need that kind of support, the more that they're going to need support in terms of stress and family support in order for them to recover. all students are going to come in having learning deficits. And as educators, we really need to be prepared for the ongoing need for remote learning structures, because this certainly won't be the last time that children will need to rely on alternate methods of education, not only when we're dealing with pandemics, but also when we're dealing with crisis in terms of the environment that we may see coming into play more and more. So what can we do to really help children in the classroom? Well, the first thing is we really need to be gentle with the students, the parents, and ourselves as educators. When we divide up the work, we know that children haven't seen each other for a long time. We're going to have to allow time for socialization. We're going to have to realize that everybody has slipped in terms of learning and not keep hitting up on that frustration. We're going to need to keep that remote communication that we've had to do during the pandemic in place, knowing that contacting families is going to be extremely important when we help them and support them dealing with the ramifications of the virus. And we're going to make sure that we don't throw away any advances made, especially when it comes to remote instruction, as this is something that will continue throughout these children's lives and through as we deal with the after effects of the pandemic. So thank you so much for attending today. Thank you.
Hello again, this is your host, Dr. Edward Halperin, with information for those of you who wish to get continuing medical education credit for participating in today's webinar. You have 3 ways to get your CME credit. You can send a text message to 828-295-1144 and type in the code 94PROP, P-R-O-P, all capital letters, 94PROP. And if you do that, you'll get a response text message back with instructions as to how to fill out your satisfaction questionnaire with today's webinar and how to get your CME credit. If you don't want to use the text message route, then go to the website www.eeds.com. Click on the sign-in button, enter that same code, 94PROP, and you will once again get instructions as to how to get your credit. Or you can use that app on your cell phone and scan the QR code, and it'll make a dinging sound and it will take you to the website to get your CME credit and fill out the satisfaction questionnaire. Any of the 3 ways will work, but any of the 3 ways will only work until Monday, August 30th at 12:30, when the system will shut down. So I recommend that if you want CME credit, you go on ahead and do the bit of work to get it now, so you won't lose the opportunity when the system closes down. Meanwhile, as you continue to participate in today's webinar, if you have any questions for our panelists, please type it in on the Q&A function on your screen, and we will monitor the questions and answer as many of them as we can when Dr. Kadish moderates the Q&A portion of our program. And let's return back to our program.
Good afternoon. I'm Karen Murray, Associate Dean of Admissions for the School of Medicine here at New York Medical College and Assistant Professor of the Department of OBGYN here at the college. Today, I'm giving you an update on the COVID-19 vaccines in pregnancy and lactation. About 6 months ago, I gave my first presentation on pregnancy and lactation and the COVID-19 vaccine. Since then, we've had a lot more data come in. We've had more recommendations made, and many organizations are now requiring vaccine status in order to be present and a part of the day-to-day. So for that reason, I'm hoping to answer many questions that you may have about COVID-19 in pregnancy, and as well as vaccines and how they affect pregnancy and lactation. I have no disclosures. The information today comes to you from the Society of Maternal Fetal Medicine, as well as the American College of Obstetrics and Gynecology and the CDC. Researchers are still learning how COVID-19 affects pregnancy in recently pregnant women. The current recommendations are still holding true to what they suggested earlier in the process of this disease, that pregnant women have a higher risk for more severe illness, which could require ICU admission, ventilator support, or the patients may die. They have also noted that obesity and gestational diabetes have an even higher risk of severe illness. They have noted that Black and Hispanic women have a higher rate of illness and death from COVID-19, not so much because they're more susceptible, but more likely to face social, health, and economic inequities, which puts them at greater risk. How does COVID-19 affect the fetus? A lot of this research is still ongoing. We do have a few anecdotal cases where there seems to be an increased risk in preterm birth and stillbirth for women who have COVID-19. There was also a public study that showed a fetus who acquired COVID-19 through vertical transmission. This again is rare and has not really been substantiated by any other studies. We do know that after birth, a newborn can get the virus if they've been exposed to it. So let's talk a little bit about vaccine safety and pregnancy. Again, as I presented earlier, many of the early studies did not include pregnant patients. And there's a limited amount of safety data that was available on the COVID-19 vaccine as it pertains to pregnancy. Based on how the vaccines were made and the science behind how the body works, experts believe that they should be safe in pregnancy. Tests with pregnant women are now in progress. There are many thousands of pregnant women who have already chosen to receive the COVID-19 vaccine, and they're using information from those women to help to guide the safety of the vaccine. A vaccine may protect you from severe illness, which could help both you and your fetus. So in looking at the vaccine safety profile, the most common side effects have been injection site reaction, fatigue, chills, muscle aches and pain, joint pain, and headaches. The most common for all three vaccines seems to be the injection site reaction. I want to take a few minutes on this particular slide. The information here was composed from the CDC vSafe registry, and there was a preliminary study published in the New England Journal of Medicine in April of this year, where they looked at the results of over 139,000 pregnant women who have received the COVID vaccine and who have registered with the vSafe registry. So the things we're looking at on this slide are pregnancy outcome as well as neonatal outcome. What they've done is they've compiled the background rate for all these outcomes and compared those to the patients who were registered in the registry. So in terms of pregnancy outcome, we're looking at miscarriage rate versus stillbirth, miscarriage being less than 20 weeks and stillbirth being 20 weeks and above. And what they've seen is that there is no increase from the background rate in the patients who were registered in the registry. When they looked at gestational diabetes, preeclampsia, gestational hypertension, as well as intrauterine growth restriction, again, they noted that there was no increase in the registry compared to the background rate. When we looked at preeclampsia, there were absolutely no patients in the registry who were diagnosed with eclampsia. Looking at neonatal outcomes, preterm birth, as well as congenital anomalies, again, there was no increased risk as compared to the background rate. When we looked at small for gestational age, the vSafe registry and the background rate were about the same. And when we looked at neonatal death, there was no neonatal death reported in the patients who were registered in the registry. Should breastfeeding women get the COVID-19 vaccine? The answer is an overwhelming yes. ACOG now not just suggests, but recommends that breastfeeding women get a COVID-19 vaccine, and that while they're getting the vaccine, there's really no reason to stop breastfeeding if you want to get the vaccine. So just sign up, get your vaccine, continue to breastfeed your baby. When you get vaccinated, the antibodies made by your body can be passed through breast milk and can help to protect your child from the virus. If you have COVID-19, should you breastfeed? It is not likely that COVID-19 can pass through breast milk itself and cause an infection in your baby. Most information shows that it is safe to feed breast milk to your baby when you have COVID-19. Breast milk is still the best source of nutrition for babies, and it helps to protect them from infections that would include ears, lungs, and digestive system. For these reasons, COVID-19 should not stop you from breastfeeding your baby. So then you're going to ask, well, if I have COVID-19, how do I protect my baby? Use a face covering whenever you're holding your baby, and that includes breastfeeding your baby. Do not put a mask on your baby or cover your baby's face. Wash your hands before touching your baby. Wash your hands before pumping. Wash your hands before touching any bottles or paraphernalia that has to do with the breast milk that you want to feed to your baby. And if possible, and you have someone by you who's healthy, then you can pump and have that person feed that breast milk in the bottle to your baby, and they should also wear a mask when doing so. So preconception vaccination. Many patients are asking, should I get the vaccine if I'm planning to become pregnant? And again, the answer is yes. There was a study published in Fertility and Sterility by Dr. Morris in June of this year, where he looked at the SARS-CoV-2 spike proteins, both from patients who were vaccinated and patients who've had COVID-19 infections. And what he found was that there was no effect on fertility. There is no evidence that COVID-19 vaccines cause infertility. Some COVID-19 vaccines will require 2 doses. If you find that you're in between doses and you have a positive pregnancy test, the recommendation is to get the 2nd dose, because it's not until you've gotten the second dose that you're considered fully vaccinated. In terms of vaccine preference, all 3 available vaccines have been proven to be safe and highly effective. Whether you're pregnant or non-pregnant, you can choose to get any of the available vaccines. The vaccine cannot give you COVID-19. None of the vaccines use the live virus. The vaccines do not affect your genes or DNA. There is no evidence that the COVID-19 vaccines cause infertility. And for that reason, ACOG now recommends vaccination for anyone who may consider getting pregnant in the future. So what do you do if you want to get pregnant? Wait until the pandemic is over? Pregnancy is, as much as everything else, is a personal choice. You should take steps to prevent exposure to COVID-19, whether you're pregnant or unpregnant. And again, the recommendation is if you're thinking about being pregnant sometime in the near future, go ahead and get yourself vaccinated as soon as possible. COVID-19 vaccine developments and regulatory approvals are rapidly progressing. Information and recommendations will evolve as more data is collected about these vaccines and their specific use in the population. Again, I hope the information I provided was helpful, and I answered most, if not all, of your questions. Thank you.
Hello again. This is your host, Dr. Edward Halprin, with a word about how you can support this program and others like it that you have been watching. We hope you understand that while we are happy to provide free CME credit and provide these programs at no charge, providing these programs has real costs for the college in our time to prepare these lectures, to prepare the slides, and the technical work to put together programs like this. We hope you'll consider making a tax-deductible gift to the college to offset the costs of doing these programs or support our research in virology, including on COVID-19. Great things are happening at New York Medical College, and we hope you'll want to be a part of it. We ask that you consider making a gift to this program, to the college, by either phoning 914-594-2720, and a real person will be happy to answer the phone, take down your credit card information, and take down where you'd like your gift directed, either to these webinars or to our Virali research, or to whatever you desire. Or you can go online to www.nymc.edu/give and make your donation online with a credit card. And finally, if you'd like to get out that checkbook and take a pen and write a check to New York Medical College and put on the memo line where you'd like the money to be directed to, we will be delighted to receive it at New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. We do hope you'll consider supporting this program and our COVID-19 research. We thank you for thinking about us during these challenging times. We hope you're all staying safe and healthy. And now it's time to turn to the question and answer portion of our program, moderated by the president of the Touro College and University System and New York Medical College, Dr. Alan Kadish. Dr. Kadish, the podium is yours.
Thank you very much, Dr. Halpern. So the first question we'll ask is for Dr. Montecalvo, which is, isn't the data on whether or not you need the vaccine after you've had a proven COVID-19 infection somewhat contradictory? Are we really sure that the vaccine is helpful in people who've already had a COVID-19 infection?
Thank you for the question. So regarding natural infection, I think we know that we are not surprised to see reinfection after natural infection, right? We saw that with general coronaviruses. And so it's not a surprise that there's reinfection after natural infection. And I think the vaccine is needed to boost the immunity. And as I said, there are data that it even gives a broader immunologic response. Thank you.
Sure. Next question is a question about the flu vaccine, which is given annually, and a potential COVID-19 booster. Do you think there's any interaction? Should someone wait some period of time between getting the two vaccines?
Yeah, thank you for asking that. That's a very important point as we approach September and the onset of receiving flu vaccine. So if it's true that that the public is going to be having boosters beginning at the end of September, I think that one way to approach this would be to get your flu vaccine first. And the reason I say that is, first of all, I'm sorry, I should back up. There is no contraindication to receipt of the two vaccines simultaneously. It is simply recommended to give them in two different arms. However, given that we want to know what the side effect profile will be to a third vaccine, I think it's a good idea to separate them in time. And since it doesn't appear that boosters will be out for another month, perhaps this year we should get started earlier with our flu vaccination and get it done, and then proceed to get our COVID vaccine.
Sure, that sounds like a good approach. Thank you. So a couple of additional questions. One is about the third dose of a vaccine. Should you get the same vaccine you got originally? If you got a Pfizer vaccine, should you get a Pfizer vaccine? Or should you get a different vaccine as a third dose? There have been some data to suggest that you can get additive immunity by mixing two kinds of vaccines.
Yeah, that's it's an excellent question and complicated. The recommendations are to receive the same vaccine, but if for some reason you had the messenger RNA vaccine, and should you receive the other messenger RNA vaccine to interchange those, CDC does say that that is acceptable. I think it's really important to stick with the data and the studies that, although there are some data looking at interchangeability, the primary studies are looking at administration of a third dose of the same vaccine, and that's what is known for the most part. And I would stick with that unless for some reason you couldn't receive that vaccine.
Are there studies going on to see if mixing and matching will be better?
I believe there are, but I am not familiar with any of those results.
Okay, thank you. There's some more questions for Dr. Montecalvo, but I think we'll let her take a deep breath or two and go on to some other questions. So, a question for Dr. Gilliar. Someone suggests that we may not know the impact of the change in medical education for those students who were educated during the COVID pandemic for quite some time. Are there longitudinal studies planned to see what the impact on physician training long-term will be from the COVID pandemic?
At this juncture, I don't know of any study that's actually in place already, but we have done exactly those kind of thoughts in trying to implement the progression of medical students through the undergraduate medical education, which is medical school, through graduate medical education, which is the residency, and then how practice comes out after they are done as a physician and working as attending physicians. But after hearing this morning's presentation, it is very clear that we need to even go further back as to see what are the competencies that the students bring to high school and even to colleges, so we can actually plan according to see if there's some sort of deficits that we have to, over longitudinal planning, get actually up to date.
Thank you.
That's a great question. Thank you.
So last year, there was a lot of talk about graduating medical students early and having them enter the workforce to try to help with the pandemic. Has any of that been happening this year? Is it necessary? And have we thought about graduating people early?
Yeah, interestingly, this year, this has not even been on the radar much, if at all. I think last year it was a matter of the acuity of the situation. We were still improvising as to move forward, and we were looking at all hands on deck so that this came about as one of the solutions and contributions from the medical school world. It's my understanding that about 18 to 21, 22% of medical students took advantage of that last year, and there were special circumstances that supported that, and we learned a lot through it, also legally and logistically. And so I think it's a matter of the workforce that differences that we had last year to this year. Great question. Thanks.
Okay. Have you seen students who don't have access to technology who've had trouble with remote learning because of that?
Yeah, actually, that's a very good question. We at our school, we did an immediate canvas of our students, what technology they had and did not have, and for the the students who did not have, let's say, a laptop or a smartphone, we tried to give loaners, especially laptops, and I think our students were able to pool resources together. But I hear of other issues of other programs where there, if the support was not there, access was crucial. And like anything else in medicine, access and quality and the cost really come together. And so that is something that we have also identified as an issue, as well as personal isolation, not being able to come into cohorts and meeting with friends. So the more we look at that, it really comes back to the social determinants of health. So yes, great question. Thank you.
So tell me a little bit about telemedicine. You spoke about how telemedicine sort of was resurrected or sort of dramatically increased during the period of COVID. What are we doing about telemedicine going forward? Do we have programs in place to train students in telemedicine? How's that working?
Yes, telemedicine has really become one of the new pillars of interactions, and I think it will stay to be part of a medical visit where it saves patients to have to drive, especially if they have mobility issues. So it's a positive thing there, and also for just a routine flow. So we feel that telehealth is not only a good pillar, but one that is actually crucial and absolutely necessary and pivotal. We are now starting to integrate the use of telehealth in our pre-rotation curricula, but most importantly, our students get direct hands-on experience while they are in their rotations. And what they have learned is that specifically you learn to get very good at asking very good questions. The history and physical, the history part of the history and physical examination of a patient leads us in the direction of asking good questions and having that first contact with the patient. And overall, we find patients like this, but we have to fine tune this as to how best fit it into the entire patient visit.
That's great. So one last question for you, Dr. Gilliar. You talked a lot about how we adapted education to the COVID pandemic and what changes were put in place. But are there areas where you think the students perhaps didn't get the same experience? Were there challenges where you think that things perhaps even for the future might be influenced by the fact that students had a different kind of education?
Yeah, absolutely. And part of that is the socialization part, which is very important for our student cohorts to speak together, be together, practice together, and work as a team. We were not really able to fully take advantage of that. And I formulated a new axiom from Dr. Montecalvo this morning where she says redundancy and repetitions rules. I really think that we have lost out on that opportunity. And so what I'd like to think that we moving forward is to specifically pay focus to integrating skill set development, ability to think critically. I have a feeling we did the basics that we could get across. We were able to carry that ball to the end zone. But really, what we need to do next is that the skill development in any which way, and we need to also work with our program directors in residency, what they expect, so that there will be a real good communication and the development in that direction.
Thank you so much.
Thank you.
So there are a couple of questions for Dr. Murray. Dr. Murray, unfortunately, is dealing with a medical emergency. And so I'm going to try to read the questions and provide the answers that she did. One question was about high-risk pregnancy. In patients who have a high-risk pregnancy, is perhaps the risk-benefit ratio of the vaccine different? And should such patients with high-risk pregnancy still receive the vaccine? And Dr. Murray's answer is that it's recommended for all pregnant women, and that there now have been multiple studies, including some finished this week, that show that the outcome with the vaccine is better for pregnant women and their babies than not being vaccinated, and that includes high-risk pregnancy. The second question is, what should someone who's nursing and gets a booster shot and gets fever or muscle aches, are there drugs that such a person can take to help relieve the symptoms? And so the answer there is, first, there are no cases of COVID-19 being transmitted in breast milk or any problems transmitted post-vaccine to the fetus. So one can be comfortable that the vaccine can be taken by pregnant women, as we discussed. And if you do have a fever of myalgias or muscle aches, you can take Tylenol. There's no contraindication to taking Tylenol during breastfeeding. So those are Dr. Murray's answers. I hope I did them justice. There are actually a few questions for me. One of the questions is, if the vaccination process goes well, that's great. But what if the proposed mandatory vaccine policy at New York Medical College in Touro, what if someone gets sick? Are we prepared to pay for costs, legal costs, and the lasting consequences? So it's a good question. The answer really is that colleges and universities, like employers, are in a no-win situation. If we don't mandate the vaccine and someone, say a faculty member, gets sick and dies, then we're potentially liable. And if we do mandate the vaccine and someone has side effects, we're potentially liable. So there's no way to make sure that there's never any liability. In view of that, we've done what we think is medically the right thing to do, which is mandated vaccines throughout. The second question is, should we be requiring vaccination and regular asymptomatic testing of students and employees? And should we be requiring masks even for those who are vaccinated? Both of those are very good and complicated questions. And what I would say is that we have not yet decided to engage in a comprehensive testing program for those who are already vaccinated. And the mask requirements really depend on the setting and the school. So in some of our health science campuses, masking is required even for those vaccinated. In some of the general campuses, we haven't yet required that. And I think the issue of testing and universal mask wearing really will depend on the evolution of the clinical pandemic. Right now, we're comfortable with our current policy. But if things get even worse, we will consider asymptomatic testing and screening and a universal mask wearing policy. So let me now get back to Dr. Montecalvo, and not surprisingly, many of the questions are clinical and related to that. So there are two related questions, one about school extracurricular activities and one about international travel. And the question is, given the current state of the pandemic, should we be having extracurricular activities at school? Should we be contemplating international travel?
Of questions. So I think with each of those, you have to really think about what you're trying to accomplish. So beginning with extracurricular activities, which can be very beneficial to students. I always like to say, is there a way to still do this, just do it more safely? You know, so masking, incorporating some distancing, symptom temperature checks before the activity. I think there's a lot of careful steps that can be taken before you just cancel. And, you know, not least of which is making sure that everyone understands that even if you're vaccinated, if you have mild symptoms, you need to be tested because you may have a breakthrough infection. And so, you know, I think it depends upon the activity and what can be done safely. You know, in the past, of course, they were canceled, but I'm hopeful that with a stepwise approach, layering various preventative measures and, you know, practicing that redundancy, that we might be able to get through further. That would be my sense. As far as international travel, it really depends upon why you're going, what you hope to do when you're there. Will you be able to do that? You know, if you're going to visit a relative and you're going to be in their home and this is your chance to go, I mean, you want to go. If, you know, remember that we are in a high transmission state in most of the United States, right? So it's not like other countries are so much worse. We're not in too good a shape right now.
And what about flying? Are you concerned about flying and what's going on in planes? What's the risk there of getting on a plane and flying?
Yeah, well, you know, the air circulation in planes is actually quite good, you know, but clearly who's immediately around you and the rows, you know, a couple of rows in front and behind you are problematic, and the planes are packed right now. So, you know, it is a risk. I would I would certainly, you go with a face mask, of course. I would probably bring eye protection with me. And I would be careful that I have my own hand sanitizer and really keep my area very clean. And I would be careful that if someone next to me takes off their mask besides to eat, I would ask them to please put it back on. I mean, I think you have to be very careful.
Yeah, let me follow up on your comment about the hand sanitizer. So early on in the pandemic, before the routes of transmission were fully understood, there was tremendous care being placed on cleaning surfaces, even wiping down groceries and things like that. And, as things have gone on, there's been this sense that physical contact as opposed to respiratory transmission is a less prominent mode of spreading of COVID-19. So is the hand, are we still in a stage where you think that being extraordinarily careful with hand sanitizers and perhaps glove wearing is needed? Where does that stand right now?
Yeah, so we've learned that the physical surfaces are not as much of a risk, and that, as you already said, it's primarily it's respiratory transmission. But you can't disinfect your hands often enough as a general rule. So, if someone coughs or sneezes near you, or you don't even see that, right? But someone's speaking and maybe asymptomatic, there can be particles that, are going to land and you're going to touch things and pick it up. So I do think, I wouldn't disinfect my groceries, but I certainly would, practice regular hand hygiene as often as possible and carry alcohol hand sanitizer with you.
Okay, thank you. What do you predict will happen about vaccination for children 12 years age and under? Do you see that coming soon? Where are the studies, and what do you think clinically about that?
Yeah, I know that there are data. I don't know the time frame of that, but I would imagine that will be forthcoming. I mean, in general, if you look at the adolescent data that were presented, the immunologic response, at least to the messenger RNA vaccine, was even greater amongst adolescents than amongst the adults who were in the original study. So, I unless something unusual happens, I would think it's going to be forthcoming. I just don't know the time frame offhand.
Okay, thank you. There's now a more technical question. There are two outpatient antibody tests, nucleocapsid and spike domain. What's the difference? And if first of all, is there an indication for getting antibody tests? And if one does, which of the tests, what do the different tests mean, and which would you get?
Yeah, so thank you very much for asking that, because that's a very important area. You're not supposed to use any of those tests right now. The commercial tests right now are not, consistent with the laboratory evidence of immunity, like the neutralization tests and the other things that are being done. And it is not recommended to test. So, for example, if you think about the data that I presented on the immune suppressed, right? So there were people who were seronegative in laboratory studies, and then they gave them a third dose. The natural question is, well, gee, shouldn't I test before I get my third dose? And CDC, FDA, ACIP, everyone says no. It's because the commercial tests are not at the point of being accurate enough. So it doesn't matter which one. Right now, antibody testing is not recommended.
Okay. And the final question that I'll ask you is, someone asked about a fourth dose of vaccine, but putting that more generally is, do you see modifications of the COVID vaccine coming? Do you think we'll need an annual COVID vaccine? Is it too early to tell? What's your thoughts about that?
It's awfully early to tell. A fourth dose, is really going to depend upon what the data and the duration of immunity look like after the third one, right? And all of that is still forthcoming. But I would imagine on an annual basis that we could end up with an annual vaccine. I mean, this virus certainly has demonstrated its capacity for change, right? And, you know, we don't know how it's going to change next. So it seems logical that this is the type of viral infection that will need some kind of ongoing booster. But in terms of a fourth dose soon, I think you have to wait for the data on the third dose.
Okay, and so the final question there, I guess, would be, if you're 6 months from your dose, would you get a third booster right away, or would you wait to see what's happening with the virus and determine whether a modification of the vaccine will come forward that would be better than a third dose of an existing vaccine? How quickly would you rush to get the third dose if you can, once it's approved?
I would follow the guidance that comes out from the FDA. I mean, I think you know, I would look to see this, you know, what they present when they review the studies, and I would follow the guidance at that point. If they say wait for 6 months after dose 2, I would do that. You know, because it's based upon the studies. You know, I just want to mention that the meetings of the American College of Immunization Practices are open to the public, and they're extremely informative. And you just Google ACIP and you'll see their meeting. So, you know, I would follow the recommendations based upon the data that they review.
Thank you so much. So thanks to the audience for some great questions. There's still a bunch that we haven't been able to get to, but we'll look forward, unfortunately, as Dr. Halpern said, to seeing you again. COVID-19 is something we're going to have to continue to deal with, and New York Medical College in Touro will continue to try to provide information to help all of us through it. Thanks again for attending, and we look forward to seeing you in the future. Take care.